The building of negative pressure rooms, that has become such an important part of infection control and prevention since the COVID-19 pandemic upended our lives. I'm Frank Diamond, Managing Editor of Infection Control Today, where we try to give infection preventionists and others on the front lines battling COVID-19 the information they need for that battle. We've reported about how many hospitals have had to build negative pressure rooms on the fly because of COVID. But what about long-term care facilities? You'll recall that many of them have been the nexus of COVID in their communities. How do you go about creating a negative pressure room in a nursing home? That brings me to my guest, Cedric Steiner, who was very much involved in building a negative pressure room at a nursing home in Lancaster County, Pennsylvania. Cedric, thanks for visiting us here today at Infection Control Today.
Yeah, thank you. Thanks for having me.
So could you tell us a little bit about yourself and how you got involved in a project to build a negative pressure room in a nursing home?
Sure. I was originally a teacher. I taught high school biology for about 18 years, and then I went on to do an MBA in health administration, and partnered with a gentleman who was a longtime CEO in Texas, and he had gone on to do work internationally in infection control, nosocomial infection type stuff in international hospitals. And we kind of come together as a partnership to work on international medical travel. And in the meantime, I also went on to nursing home administration. So I found myself in a nursing home working on the practicum component of a nursing home administrator's license right when COVID hit. At the meantime, I had this partnership with a hospitalist where we were working, looking internationally, and that all had to shut down, of course, because of COVID. So putting two pieces together, well, that's a little bit of the background, I guess. That's probably good for a background. As far as where I'm at academically. It was actually really exciting. I actually enjoyed it. I mean, it was a great time to be there. People kept saying, I hope this doesn't turn you off to nursing home administration, but it allowed me to get right into it. And it was about 2 or 3 weeks when I was in, and I was actually more concerned about the facility not being allowed to have me there because I was an intern. And we were really beginning to shut down. I mean, there were talks in Pennsylvania of not having students and they did at one time. They took students out of hospitals, as I'm sure you're aware of, but even the physical therapists and some of that other work, there was discussion of removing those individuals for a time. So I was happy to be there because I didn't want to get interrupted in the practicum.
And we're talking about a nursing home, right? Correct? That's
correct. A skilled nursing home. This nursing home that I was at in Lancaster County, and Lancaster County is said to be the Silicon Valley of nursing homes. We have some of the best nursing homes across the country. People come to Lancaster County. It's Amish country. It's, pristine, and they like to retire here. Moderate temperatures and so forth. So I was in a nursing home. It's a CCRC for all intents and purposes. It had independent living, it had personal care, and it had health care, which is skilled care, rehabilitation type care. Anybody that gets out of a hospital with like a knee replacement or something like that and can't go home, you might end up in a skilled facility like ours.
So what gave you the idea and what made you think you could pull it off?
Well, I gotta give a lot of credit to Shelley Miller. I did a little research, and Shelley Miller is a professor at the University of Colorado Boulder, and I think as this interview goes out, she's being featured on like PBS NewsHour and NPR and some other things. I think there's a couple of them that are really top of the field in this area of buildings, and she had worked with Nick Clements in a conversion in Palo Alto, California, where they took a hospital and they did a negative pressure ward on it. And I came across their research and I called her, and she thought maybe it was a joke at first, but actually I just got an email says our submission to the infection control. She just sent me an email and said our paper was accepted for the submission, so we're good to go. We'll have a paper out here. But
is that the American Journal of Infection Control?
Yeah, it's correct. I just as we were talking, you know how the little flip the emails come across.
Well, I'm a
So
charm then, right? So,
so uh yeah, so I reached out to her and she got back to me and I told her, hey, I want to do this. I want to do what you're doing or did. I want to do it in a nursing home. And I had some, I was definitely interested in publication. I was interested in writing and research. And her, her co-author had moved on to Well Living Lab, which is part of Mayo Clinic. And those two, along with another gentleman at the University of Colorado, a mechanical engineer, um, computer sciences, we teamed up together with me on the ground, working with the administration, kind of knowing the nursing home, what goes on in a nursing home and how things work on the ground and them, and we were able to put together both the experiment. Nick would ship me the equipment, and I had enough technical and computer expertise to kind of like get the data and collect it and set it up, and we do things over Zoom. So we put that together. I gave her a lot of credit. She was willing to go for it. The administration at the nursing home was willing to allow us to do it. So we basically put in place the suggestions that Shelley had. I would kind of offer suggestions from a nursing home's perspective, how they operate. Um, but yeah, the building management people, the environmental control specialists who are in a hospital or in a nursing home, they did the actual mechanical work. So they put in the motors and I took the data and made sure we were getting pressures we wanted and air exchanges we wanted.
so I'm trying to visualize this. So you're working in a nursing home. You're a manager of a nursing home, right?
Mhm.
And so you look around, you see a room that you might be able to use as a negative pressure, right? That already
Right.
exists.
Well, we're gonna go bigger than that because at the same time we were talking about up in New Jersey. I think they were putting that the tennis court under all negative pressure, or they were at least making a facility inside. So I wanted to do the whole wing, and the way nursing homes have traditionally been designed is that they were designed after hospital models. So they have wings and corridors. So a hospital and a nursing home, skilled nursing home, have a lot of the same features. So we needed a lot of space. So we wanted to put the whole wing under negative pressure. That was the goal. So a whole section of the facility.
Now, was there an infection prevention involved in what you were doing?
Yes, correct. According to Pennsylvania, I think it's chapter 28 of the PA code, you're required to have an infection prevention nurse, and that nurse is responsible for recording infection control methods. And like, I think it was originally to address TB and some of those type things, but more recently it has to do a lot with influenza. Um, so so yeah, we have that in Pennsylvania. Everybody is required, I believe, above. I think across the board, to tell you the truth, doesn't matter how many beds you have. So yeah, we had an infection control nurse who was on board with this as well.
So I'm trying to residents, and that
Sure.
so you had to relocate them where?
Right. So we just moved them around the facility. And at the time, hospitals were they stopped sending residents to us. Remember, they shut down a lot of their surgeries. So we were using what was a rehab wing where people from knee replacements, hip fractures, things like that would have come in, strokes. We were starting to get less and less admissions. So we were able to find the space and move people out so that essentially we had a 13 rooms, a wing that was open to new admissions.
And I'll bet a lot of people who will see this will be wondering, how long did it take you to do it? How long did it take you to get this done?
Yeah, so it went really quick. I think from the day I first met with or talked with Shelley to the day we took our admission, I think it was about 10 days. It might have been 14, but it was very quick. how we turned around. And it needed to be at that time, because in Pennsylvania, we were hearing we were going to get admissions from hospitals, and we were going to need to take COVID residents. So we knew we'd have to put these people somewhere. And there was another concern. We didn't know who would come into the facility with COVID. And so we had to do an isolation, and we didn't have the testing that early on. So you had to isolate. The best thing we could do is bring somebody in and isolate them in this ward. And since it was under negative pressure, we weren't putting a resident with another resident. And traditionally in nursing homes, it's not independent rooms. Residents share rooms, and then they share skilled nursing staff, or they share, CNAs will share, and that just spread it all over the place once you had that kind of thing. So we really were able to isolate it, not only on negative pressure, and we were being required by the Department of Health to come up with an isolation space. We just made it all that much better by putting it under negative pressure.
Now, with a project like this, how do you measure success? Well, I imagine you measure success that first off, you get it done, you get the negative pressure wing operating and functional. But then after that, how do you measure success?
Well, the way negative pressure space allowed us to treat people with COVID. We were the only nursing home that would accept a resident with COVID at the time we put this in. That was a huge success right there. Now, some people thought that was irresponsible by the administration to bring in somebody to treat them. But we were able to bring in people, we could treat them in that COVID unit, and we could then discharge them. And we did that all without kind of using it as a separate facility. So that was a huge success in itself, being able to treat people. And the other success was our own staff. And for me, kind of my area in health administration is really about staffing and protecting staff. So this made an environment where staff felt more comfortable. And I don't know if anybody else has told you this along the way, but some of the nursing staff have felt better being in infection control units than outside, where things were kind of toss up on the outside. When you went into like an AIIR room, you had all the proper PPE. You felt like, the precautions were there, and you felt comfortable. So time and time again, I would hear from staff that they felt more comfortable in that isolation space than they did maybe in other parts of the nursing home where there was more exchange and more unknowns.
Has anybody reached out to you from other healthcare institutions? I guess I'm talking about long-term care facilities. I mean, has word gotten out and they want to do the same thing?
There were immediately other facilities began doing their own type experiments with this. I don't know of anybody doing it quite what we did. We were using engineers, and we were doing it very academically on an experimental basis. I think they were calling in HVAC specialists, which I would caution anybody watching this. We had an HVAC specialist come in, and I will tell you, I was concerned with their plan. They have an idea of what's going on, but as far as infection control, your HVAC, they're not infection control people. They can do things, but I would really caution you against. You should seek professional engineering advice on these. Just don't bring in an HVAC guy and ask him to go negative pressure or do something, because they'll. In my experience, they actually confuse positive pressure with a negative pressure. So I have heard of different things like that, and I've even heard of I have heard of other solutions. But it's that in Pennsylvania, the major solution seems to be we're going to test residents and staff. I mean, on a weekly basis and so forth until we can find where we're at. So specifically, the data that we were collecting out of the rooms were actual pressures. We wanted to see the pressure. It's really called a cascading pressure zone. It's the way in which it would work. That's how you should think about it. The rooms need to be negative to the hallway, and the hallway negative to an anteroom, and the anteroom negative to the outside air. So essentially, air is coming in this facility, is always moving like away from the patient, like towards and out of the facility. So there were a lot of vents in the room. So air was coming down the hallway, out the patient's room in such a way that hopefully our healthcare providers in the hallways and in the anteroom, the air was always coming in from this, in our case, it had to come in from somewhere. It was coming in from the facility. To be supplied. So I knew those pressures. I had a continuous, I had a computer and a monitor set up in the back. I had equipment from Well Living Lab, and I would be reading those pressures and emailing them out to the engineers on a daily basis. You can only work as a nurse with tools, right? I mean, and I guess we've never really considered the building a tool. Right? I mean, do you consider the actual air or the facility, the air handling facility, a tool? And that's really where we're going. And in nursing home codes, they say, they have in the code, chapter 28, I believe, again, in Pennsylvania, says the pressure differences from like different facilities. So for example, like a laundry chute needs to be negative to the hallway. So it's usually around smell or something like that. But when we talk about infection control and not just one room, but the whole, like pieces of the facility, they're definitely on the right track. And I think thinking about the building as like a living, breathing kind of thing and getting your air and how you're going to move that air and how many exchanges you have. I think currently it's like 2 to 6 exchanges. Right. And Shelley's talking about 12 exchanges. I think they're on the right track. I think that we got to think about buildings a little differently. And I think that as far as an infection control nurse, that could be something that they need to put on their radar, is that, they can do these mechanisms, like keep track of hot zones and all those kind of things. But, maybe they need to be advocates for healthy living spaces or healthy buildings and breathing buildings. So
okay, Cedric Steiner, thank you so much for visiting Infection Control today.
Thank you.
Wish you the best of luck in all your worthy endeavors.
Thank you.